All right, we're going to go ahead and get started.
Thanks for speaking.
Okay, yeah, no problem.
This is our first talk of the academic year here at Harborview. And just a few words about the neurology lecture series. We're expanding a bit and a lot more subspecialty talks, including oncology, sleep, neuroinfectious disease. And so take a look at our list of talks. There's up to 40 talks this year. And so hopefully you'll be able to join us either in person or a webcast. Today we're having a talk on movement disorders by Dr. Shu-Ching Hu. A little bit about Dr. Hu. He did his medical school at the National Taiwan University in Taiwan, which is also known as Formosa, the old Portuguese or Spanish name. He was telling me about this earlier. And in Taipei. And then he did a PhD at Johns Hopkins University before coming to the University of Washington, where he did his residency in neurology. Then went to Columbia University, where he did a fellowship in movement disorders, and then returned back here, where he's now an associate professor at the Department of Neurology.
Okay, yeah, thanks for the introduction. So welcome to my talk. So today we'll give you an overview of tremor disorders. So when I started my fellowship training in movement disorder, that's about 10 years ago, I thought dystonia was the most difficult hyperkinetic movement disorder. But toward the end of my fellowship, I realized tremor was probably the hardest one. So I'll try my best to explain to you why. Yeah. So in general neurology, the key to diagnosis is localization. But in tremor disorders or any other hyperkinetic movement disorders, the key becomes phenomenology. So in other words, if you don't have a phenomenological diagnosis, you don't have a diagnosis. So we use phenomenology diagnosis to figure out etiology diagnosis. On the other hand, once you have a phenomenological diagnosis, even you don't have an etiology diagnosis, you can still provide quite effective treatment for symptoms. That's why phenomenology is a key in hyperkinetic movement disorder. So what is tremor? So the definition is tremor is rhythmic and oscillatory movements. When we see patients with tremor, we pay attention to a number of things. The most important is what we call activation pattern, whether the tremor shows up at rest, in position holding, or with action. There are also other important features such as distribution of the tremor, the frequency of tremor, and the amplitude of tremor. But still, the most important clinical feature when dealing with tremor disorders is the activation pattern. So if a tremor is a resting tremor, it's Parkinsonian tremor. If a tremor is postural and kinetic tremor and the frequency is fast, it's essential tremor or essential tremor-like tremor. If a tremor is more kinetic than postural and is slow, most likely is what we call cerebellar outflow tremor. So these three tremors, Parkinsonian tremor, essential tremor, and cerebellar tremor, cerebellar outflow tremors, they're the three pillars in tremor disorders. So they're the focus of today's talk. But obviously, there are other types of tremors, and there are also a number of tremor mimickers. They can be challenging to diagnose. I think that's why I think tremor disorders are the hardest of hyperkinetic movement disorders. So I'll go over this hodgepodge of things after going through the three pillars first. Okay, so this example of essential tremor. So her tremors are in both hands. They're purely postural and kinetic. She did not have rest tremors of any sort.
Now I would just hold your hands up in front of you.
А теперь, пожалуйста, вытяните руки вперед.
Like holding a tray.
Вот так.
Good. And now point to the camera.
А теперь покажите в камеру. Носу и в камеру.
Okay, so this is a typical example of essential tremor, but it's pretty severe. So essential tremor is the most common movement disorder. Affects about 5% of the population, but in most cases, it's mild, so they don't seek medical attention. So essential tremor has two peaks of age of onset. The early one from teens to 20s, and the late ones, usually in the 60s. In most cases of essential tremor, the presentation is very typical. Like we saw in the previous video, it's bilateral, fast, postural, and kinetic. Typically, affect both hands. It can spread out, to other parts of the body like face, head, tongue, voice, trunk, and legs. But usually, it's a hand predominance. Essential tremor is considered a benign tremor disorder because progression is very, very slow, like over decades. And patients with essential tremor, they only have tremors. They don't have other neurological deficits. So that's why it's considered a benign tremor disorder. And about half of patients with essential tremor, they have a positive family history. And about half of patients with essential tremor, their tremors improve with alcohol consumption. So with this typical presentation, as in most cases, the diagnosis of essential tremor is very straightforward. But the diagnosis becomes challenging when things get atypical. For example, essential tremor can also show up at rest, and it's not uncommon at all. The rule of thumb for the progression of essential tremor is that with age, essential tremor gets slower, so frequency decreases. Amplitude increases, becomes larger, and start to show up at rest. So it's not uncommon at all to see in elderly patients with long-term essential tremor to start having resting tremors. So again, as a rule of thumb for the progression of essential tremor, frequency decreases, amplitude increases, and start to show up at rest. So that's not too challenging. And again, in most cases of essential tremor, distribution of tremor is bilateral, overall symmetric. But sometimes, the distribution can become quite asymmetric, or occasionally unilateral for the first several years after onset. So the diagnosis can become challenging when it's not very symmetric. And also, diagnosis of essential tremor becomes challenging when it becomes what we call bulbar predominant, affecting mostly face, neck, or voice. Sometimes it gets a little bit confusing with dystonia. And also from time to time, we encounter patients who have long-standing essential tremor and later develop Parkinson's disease, or we encounter patients who have long-standing essential tremor and eventually develop other neurological deficits like ataxia, Parkinsonism, or dementia, something called EP+. So the jury is still out as to whether there's a biological link between essential tremor and the Parkinson's disease. But most people agree that essential tremor, especially in elderly people, may not be as benign as we thought. So in other words, it's no longer monosymptomatic. In elderly patients, you can adopt a neurodegenerative flavor toward the end. Okay, so this patient, essential tremor, is an isolated head tremor of the nodding or ESCS type. Okay, so if I remember correctly, he did not have hand tremors at all, just isolated head tremor of the pure nodding type. Okay, so this patient's essential tremor is also an isolated head tremor, but of the shaking or no-no type. Okay, so what's the difference between yes type and no type? In terms of medical treatment, pharmacological treatment, not too much difference because most of the time medication just don't help. The difference, Botox injection is more useful for no tremor and less useful for yes tremor for technical reason. So it's still kind of relevant. Yeah, I'm going to show one quickly. Yeah. Okay, so this patient's essential tremor affects mostly her face and jaw. As other patients I just showed, she didn't have obvious hand tremors.
So, if you don't mind, just look at the camera.
Okay, so there's another kind of variant of essential tremor that affect mostly the face and jaw. And finally, as promised, her essential tremor affect mostly her voice, and the voice tremor was confirmed by laryngoscopy. She also has mild neck tremor, and there's a very strong family history of essential tremor.
Speech 20 years. Now just say E, hold it as long as you can. Okay, stop. Now say ah, hold it as long as you can.
Okay, so that's a very typical essential tremor effect in the voice. So you hear sometimes voice tremor, but more often it's very rhythmic, voice break, usually about 1 to 2 hertz. Sometimes it can sound like a spasmodic dysphonia. So laryngoscopy becomes the key. Usually laryngologists, they can tell whether it's a low frequency essential tremor or it's a spasmodic dysphonia. Okay, so here's a summary of treatment available for essential tremor and their levels of evidence. So the first line medication for essential tremor are propranolol and primidone. But again, just keep in mind, not everybody improve this medication. Only about 50% of patients with essential tremor they respond to first line medications, and the degree of improvement is about 50%. The medication are unlikely to get rid of tremors completely. If the first-line medications don't help enough, or a patient cannot tolerate those medications, we move to the second-line medication like topiramate or gabapentin. For head tremor or for voice tremor, Botox injection can be quite useful, especially for no head tremor or for voice tremor. Usually we skip medication, just go straight to Botox injections. For refractory essential tremor, obviously DBS is the last resort. And the target of DBS is ventral intermediate thalamus.
Is there any additive benefit with the first and second line?
Yes. Yeah. A second line medication, they really work on their own. So usually they are add-on medication to first line medication. Yeah, good questions. Okay, so again, for refractory essential tremor, the last resort is DBS. But DBS helps more limb tremors than axial tremor, like the face or voice tremor. So axial tremors caused by essential tremors are still very challenging, even with DBS. And people have tried Xyrem for refractory essential tremor. So Xyrem is sodium oxybate, so it's a GHB. So it's approved for narcolepsy. So people try that for refractory essential tremor. So this patient has medication refractory tremors, and he also had a lot of side effects from many of the medications. Botox helped his head tremor a little bit, but not enough. He really wanted to have DBS, and he got it. So again, his essential tremor is an isolated head tremor. of the mixed nodding and shaking type.
My glasses in the it's okay. Keep close your eyes.
So mostly nodding, but sometimes no shaking. So every DBS.
How are you feeling right now after we turn on your DBS?
Better than I was before. I still have a little bit, but I can feel it wanting to come on.
Can you close your eyes?
So maybe very slight. Yeah. Okay, so that's an example of a single tremor treated with DBS. Okay. So so she has severe and medication refractory essential tremor affecting her both hands, her neck, and also her voice. She got DBS on the left side, so left VIM DBS. So her right hand tremor improved. But obviously her left hand tremor and her axial tremor did not improve. But gradually she developed ataxia, so which I think is a part of the neurodegenerative evolution of essential tremor. So she was not a candidate for the second side DBS because that would make her ataxia much worse. But she was still very bothered by her essential tremor. So I started Xyrem.
See, this hand is shaking more.
You can put your hands down. Now use your right index finger. Touch your nose. Now reach out to my finger.
So right hand is
Back your nose.
DBS.
Reach out to my finger. Back your nose again. My finger. Good. Now do that with your left hand. Your nose.
Left,
My finger. Your nose. My finger. Again, your nose. My finger. Good. How's your tremor now?
it's fine.
It's fine. It's better?
Yeah.
And can you hold your hands up? Use your right index finger. Touch your nose.
What am I doing now?
Touch your nose.
So she can
Touch
look
my
at
finger.
Yeah, with
Back your
Xyrem.
nose. My finger. Now use your left hand. Do the same. Your nose.
What?
Touch your nose with this finger. Touch my finger.
Okay, so her refractory essential tremor improved mildly with Xyrem, but Xyrem is very tricky to use. For narcolepsy, obviously they take that at night, so you don't have to worry about sedation or confusion. But to treat essential tremor like hers, they take that during the day. So you have to be very careful in titrating the dosage. Usually I do that in person in clinic. I ask them to bring their Xyrem over. You can see the box here, the Xyrem box here, and I just do the titration, the dosage increase in clinic, and watch them for 2 hours. The duration of Xyrem is very short, 3 to 4 hours. So watch them for 2 hours. They have to dosage increase, make sure they're doing okay. So it's pretty involved in the process. So people have also tried Xyrem for refractory myoclonus, like Lance Adams myoclonus or myoclonus dystonia. But it's really a pain in the ass to use. The main reason is that it's used as a day rape drug, so it's highly regulated. So you have to be in the registry to be able to prescribe that.
Just one pharmacy.
Yeah, it's centralized pharmacy. Yeah.
And Gene, the difference between, this was
Positremor, yeah.
What's the difference between this and this? Or you use one for one situation,
Uh,
or they're interchangeable?
Yeah, good question. Okay, so the question is that the certain specific positions matters when evaluating patients with tremors. Yeah, it does. If I think the tremors look like essential tremor, usually I don't bother checking a number of different positions. But if the tremor look to me like dystonic tremor, which is a tremor mimicker, usually I try to check the tremors in different positions to see if I can find something called null point. So I will show you several examples later on. So for a postural tremor, it can be essential tremor, it can be dystonic no tremor. But essential tremor does not change with different positions, where dystonic no tremor can change with different positions. So that becomes important for dystonic tremor. Yeah. Okay, so we're done with the first pillar. Let's move to the second pillar, cerebellar tremor. So there are two types, the outflow type and hemispheric type. Outflow type, for some reasons, is more common than hemispheric type. So the cerebellar outflow tremor is also known as Holmes tremor or rubal tremor. So it's caused by a lesion along the cerebellar outflow tract, which runs from the cerebellar dentate nucleus to the red nucleus in the midbrain, and then eventually to the thalamus. So Holmes tremors is more kinetic than postural or resting, but usually it's a combination of things. Slower, less than 3 hertz, tend to be more proximal compared to essential tremor. And obviously, patient with outflow tremors, cerebellar outflow tremors, they have additional ataxic or brainstem deficits. So diagnosis usually is not too challenging because they have other neurological deficits. Unfortunately, in most cases, cerebellar outflow tremor is medication refractory. Even with DBS, the response rate is about 50%. So the response rate of DBS in essential tremor is like over 95%. For cerebellar outflow tremor, response rate is about like 50%. Also depends on the location of the lesion. If the cerebellar outflow tremor is caused by a lesion closer to the dentate nucleus, it's more likely to respond to DBS. But if the lesion is more distal, closer to the thalamus, it's less likely to respond to DBS. But anyway, it's challenging. Okay. Cerebellar hemispheric tremor is caused by a lesion in the cerebellar hemisphere, and it looks like essential tremor. It also responds to medications for essential tremor. Okay, so this patient is HIV positive and had toxoplasma infection maybe about a decade ago, affecting the thalamus, and then later on developed cerebellar outflow tremor, mostly of his right arm, because the left thalamus is more affected than the right thalamus. So again, for cerebellar outflow tremor, if the lesion is above the decussation of the superior cerebellar peduncle, it becomes contralateral. But for cerebellar hemispheric tremor, it's ipsilateral. So it's very interesting, the localization. So
Let's try that one more time. Hold your hands up. Okay, hold your hands like this.
So not just distal, but also cross.
Hold your hands straight out. Now use your left index finger, touch your chin. Okay. Now reach out to my finger. Back to your chin.
So left side is fine.
Reach out to my finger. Now let's try that with your right index finger. Touch your chin. Reach out to my finger. Back to your chin again. Reach out to my finger.
Okay, so cerebellar outflow tremor is slower, is a mixture of resting, postural, and kinetic tremor, but more kinetic. It also looks kind of irregular and coarse than other type of tremors. Okay, so he's scheduled for DBS next month.
So ability, yeah.
Thalamus, so unlikely to respond. So we're going to try different targets besides VIN, because there are also case report using targeting zone 9 insertile subthalamus for cerebellar outflow treatment. So it's going to be pretty involved in DBS surgery.
But you were suggesting a lesion in the left dentate nucleus,
it should be ipsilateral, right? With the left hand, it should be left hand, left side tremor. But the left thought, if the lesion is in the left thalamus, it becomes right sided tremor.
So the outflow from the left dentate to the right.
Yeah. There's a decussation of the superior cerebellar peduncle.
Is it driven by the red nucleus or by the dentate?
I think by the whole thing, by the whole outflow tract. Yeah. Okay, so this patient developed cerebellar outflow tremor, mostly of his right hand and also his neck, after a picoid rupture that also damaged his brainstem.
How are you doing these days?
So he was a father.
Chin. Point to my finger. Touch my finger. Now back to the chin.
And more kinetic.
Touch my finger.
Yeah, so as in most cases of cerebellar outflow tremor, this tremor did not improve with any medications. Because it's a neurological impairment that was not attainable for more invasive treatment like DBS. Okay, so this patient has cerebellar hemispheric tremor caused by bleeding of cavernous malformation in the right cerebellar hemisphere. So his hemispheric tremor is in his right hand. So it's very slight, it's almost like eccentric tremor. But it's not an outflow tremor. Yeah. Nothing at rest.
Put your hands up.
So his right hand shakes a little, it's like mild eccentric tremor.
Your nose. Slowly toward the camera. Your nose, one more time. Slowly to the camera.
Okay, so there's an example of cerebellar hemispheric tremor. So it looks very different from the outflow tremor, and usually responds to medications for eccentric tremor. Okay, so we're done with the second pillar. Let's move to the third pillar, Parkinsonian tremor. So obviously, Parkinson's disease is a talk on its own, so I'm not going to dwell on it too much. I'll just focus on the tremor part of Parkinsonism. So we see Parkinsonian tremor mostly in Parkinson's disease, occasionally in Parkinson plus syndrome like MSA, or occasionally in secondary Parkinsonism, usually drug-induced Parkinsonism. The typical Parkinsonian tremor is a resting tremor around 3 to 5 hertz. But it's not uncommon to see atypical tremor in Parkinson's disease. The tremor becomes postural kinetic or becomes faster. So it's not uncommon at all. So, so of all patients with Parkinson's disease, about 2/3 of them they have tremors. 1/3 of them they don't have tremors. Of those 2/3 of patients with Parkinson's disease who have tremors, about 2/3 of them have typical Parkinsonian tremor. About 1/3 of them they have atypical Parkinsonian tremor. So just keep in mind that tremors in Parkinson's disease are not always the typical pure rolling tremors. They can look unusual. For treatment, obviously, we start with dopaminergic medication like levodopa or dopamine agonists. If tremor don't improve, and then we try anticholinergics or amantadine. For refractory medication, refractory Parkinsonian tremor, DBS is the last resort. But we target subthalamus instead of thalamus for Parkinsonian tremor. Okay, so this patient has Parkinson's disease, and he has typical Parkinsonian tremor. So just purely rest tremor. So it's right hand and right leg. And they stop. It's movements. Check your legs. Hold your right leg straight up in the air. You can disappear in position holding. Turn around. The right hand tremor continues in walking. So it's a typical Parkinsonian tremor.
How frequently is it unilateral like that?
It starts unilaterally. That's the course of Parkinson's disease. Start from one side and gradually move to the other side. Yeah. So that's why Parkinsonian tremor is usually asymmetric in Parkinson's disease, whereas essential tremor, by and large, should be overall symmetric. So this patient has Parkinson's disease, but he has typical Parkinsonian tremor. But his tremor also shows up in position holding, but not immediately. It kind of builds up in position holding in a crescendo fashion. So that's something we call re-emergent tremor. So it rests with right hand tremor. So we get pretty quiet right now, but gradually it starts to show up. As soon as you move, you stop, and then it shows up again. And builds up gradually. Okay. So in other words, the tremor re-emerges in position holding, but with some delay. So it's considered still a resting tremor, not a true postural tremor. Okay, just give you an idea about tremors can look atypical in Parkinson's disease. Okay.
Isn't that different from postural tremor? Because postural tremor, at first, and then it starts.
Okay.
And it gets worse.
Okay. So the question is, can you repeat?
Oh, my question is, how do you tell the difference between that and postural tremor, re-emergent versus postural
Okay,
tremor?
so for the true postural tremor, it shows up right away in position holding, like essential tremor. There's no delay, there's no latency. But for re-emergent tremor, it does not show up right away in position holding. It shows up gradually, in this kind of crescendo fashion. So if the tremor show up right away in position holding, it's a true postural tremor.
But doesn't there's some that get worse the longer you hold them in place.
Yeah.
At least I've noticed that with a lot of
Yeah, I think that can happen, but still, the most important thing is whether there's a latency, or not. It shows up right away or after some latency. I think probably, just with time, tremor tend to get more active. So, okay, so let's move to other types of tremor. Obviously, there's so many types, so I'll just give you some example here. The first thing is enhanced physiological tremor. It's very, very common. It looks just like essential tremor, but time course is different. So it's not slowly progressive. In the long term, it kind of fluctuates. If you want to be really, really sure about the diagnosis of enhanced physiological tremor, you have to do tremor analysis with motor physiology analysis. The key is what we call weight loading. So if you put weight on the part of the body that's affected by tremor, if the tremor is enhanced physiological tremor, the frequency decreases. But if the tremor is essential tremor, the frequency stays about the same. But otherwise, enhanced physiological tremor just look like essential tremor. But the course is different, and also physiology is different. Okay, second is neuropathic. Tremor. You also look like essential tremor. Most commonly seen in CIDP, especially in the anti-MAG type. And then drug-induced tremors. There's many drugs that can cause tremors. The phenomenology of drug-induced tremor depends on the drug. For example, lithium tremor and delta tremor look like essential tremor. whereas tremors caused by antipsychotics or caused by antiemetic medications, they look Parkinsonian. The last example here is orthostatic tremor. It's extremely rare, but it's very, very peculiar. It only happens in standing, but again with some latency, not right away. After standing for several seconds, people start to feel shaking. Frequency and the tremor goes away as soon as the patient walks. It goes away when walking. Only happens in standing. Frequency is very high, around 14 hertz. So high that you cannot see from outside, so it's invisible. So patients, they feel shaky in standing, but you don't see obvious tremors. So diagnosis can be more challenging. So this example of drug-induced tremor. So she's been on prolixin, so it's a typical neuroleptic like for decades for schizophrenia. And at some point, she developed Parkinsonian tremor. So the question for me, from her psychiatrist, was whether her tremor is drug-induced tremor or she has developed Parkinson's disease.
Oh, okay. Am I making you nervous right now?
No, well, everything makes me nervous.
Oh.
But it's not you.
Okay. Yeah. So, let me just check a few things. Can you just hold your hands up?
Does tremor look purely Parkinsonian?
Just move your fingers apart. Good. Yeah, relax. Yeah. So, can you use your right index finger to your nose? And I'll reach out to my finger. Turn on your nose. And reach out to my finger. Good. Okay, stop. So you try out with your left hand.
Yeah.
Your nose. That finger. Your nose again. That finger. Good.
Okay, so again, the question whether she has drug-induced tremor or she has developed Parkinson's disease with tremor. She cannot be off prolixin, and she's very, very anxious about what's going on. So I got a DAS scan. So DAS scan is a dopamine scan. So in Parkinson's disease, there's dopamine deficiency, so the DAS scan is abnormal. But in drug-induced Parkinson's drug-induced tremor, the dopamine receptors are blocked, but there's no dopamine deficiency. So the DAS scan is supposed to be normal. So her DAS scan turned out to be normal. So my diagnosis is drug-induced tremor. She, at least at that point, she did not have Parkinson's disease. Okay, so this is another example of tremors occurring when on neuroleptics. So he was on risperidone for a number of years for schizophrenia, and so at some point developed Parkinsonian tremor and also Parkinsonism.
So how long have you had tremors in your life?
2 years.
2 years. How about you?
3 years is Christmas.
So again, the tremor looks like a Parkinsonian, very asymmetric, resting.
Can you just walk down there one more time?
And the other motor features of Parkinson, like hypomania, hypophonia, and also gait problems. So his DAS scan turned out to be abnormal. So he had developed Parkinson's disease while on neuroleptics. So after a long discussion with his psychiatrist, his risperidone was switched to clozaril. His Parkinson's disease improved for a while, but then progressed again. So now he's on levodopa. So DAS scan can be sometimes useful if you're not sure whether it's drug-induced Parkinsonism or just idiopathic Parkinson's disease.
Stop the clozaril?
Hmm?
Stop the clozaril, I take it? And start
He's on both.
Oh.
Yeah. So so this patient has orthostatic tremor. Again, you're not going to see tremor, but she describes what you're feeling because it's very high frequency, 14 hertz.
Just sitting there, do you feel tremor in your legs at all?
No, I'm fine.
Okay, now can you please stand up? And again, let me know when you start to feel tremor in your legs.
Again, there's latency.
Beginning now. Sometimes it doesn't take very long. I'm beginning to feel shakier now.
Okay,
And I'm beginning to feel
Uh,
more unsteady.
okay, now you can start walking around.
Okay.
Do you feel tremor or just feel a little
I
bit
just
steady?
feel unsteady.
But you don't feel tremor anymore.
I don't I don't feel a tremor.
Yeah. Okay. So, so the example of orthostatic tremor usually feels shaky or unsteady, but there's no visible no tremor. So the day before this appointment, she downloaded an app for tremor analysis on her cell phone. So I could try that the next day because we had talked about this before. So the result of very quick bedside tremor analysis, we show a peak around 15 hertz. And that confirmed the diagnosis of orthostatic tremor. At that time, I didn't have a smartphone. I go one right away after. Okay, so there's an example of orthostatic tremor. It's usually not visible, but you can confirm that by tremor analysis. Okay, so now we're done with 3 pillars and other tremors. Let's move to tremor mimickers. So a number of rhythmic movements that can look like tremors, but they're not tremors because they're not oscillatory. So remember the definition of tremor is rhythmic and oscillatory movements. But for these tremor mimickers, they are rhythmic, but they are not oscillatory. That's why they're not considered true tremors. They're tremor mimickers. So here's some example, like dystonic tremor, which is actually rhythmic dystonia, or myoclonic tremor, which is rhythmic myoclonus, and other things. Okay, so again, just keep in mind they're rhythmic, they look like tremors, but they're not true tremors. And obviously, the treatment is going to be very different. For dystonic tremor, don't try medication for tremor. Try medication for dystonia. Also apply to myoclonic tremor. Try medications for myoclonus. Okay, so that's the time course of dystonia. So the dystonia has very variable time course. Can be as long as like infinity, become fixed dystonia. Or dystonia can be very, very short and quick, almost approaching myoclonus. Occasionally, dystonia becomes rhythmic, and then that gives you a flavor of tremor. We use the term dystonic tremor to describe that. Compared to true tremors, dystonic tremor is less regular, and also sometimes with something called directionality. Like if the essential tremor affect the head, yes, yes, or no, no. But there's no right turning or left turning essential tremor affecting the head. But when dystonic tremor affect the head, usually you can tell it's a kind of right turning type or left turning type, or forward nodding type or backward nodding type. In other words, dystonic tremor usually has some directionality that's different from other tremors. And also dystonic tremor tend to stop in certain positions, so it's important to check dystonic tremor in different positions to see whether you can find something called null point where tremors becomes absent or minimal. And just like dystonia, people with dystonic tremor usually have some sensory tricks that can stop tremor momentarily. So this example of dystonic head tremor. Again, look like left tremor.
Now slowly turn your head to the right side. Very, very slow.
Shaking my eyes closed.
Yeah, you can open your eyes. Very, very slow.
Become stronger.
Stay there.
Right tremor.
Now slowly turn your head to the left side. Very, very slow. As slow as you can.
The more regular it is, the more it makes me think
Stay
like,
there.
Yeah, so you stop in right turn to the null point.
And now just kind of move back to the mirror. Look at the camera.
That comes back again. So again, for dystonic tremor, it's useful to check that in certain different position. So again, it's important because the treatment for that is no longer to be medication for essential tremor. It's going to be Botox, targeting left turning, left turning neck muscles. Okay, so this is a dystonic hand tremor that happens mostly in the writing. So almost look like writers cramp.
Okay, now just yes, I think first.
Should I use this hand?
Sure.
Oh,
So because your sensory trick kind of dampens the tremor. Okay, shrug your shoulders out of the okay. Your hands up. So it rests no tremor position. You're holding maybe very slight right hand tremor. The left hand is quiet. Now slowly turn your hands inward. Again, I'm trying different positions now. That start to show up. Further down. All the way inward. Now slowly turn your hands outward. So more in pronation, less in supination. Okay, so now pulling is in supination. So if I want to try Botox, I want to drag supinate of the forearm. So this is another example of dystonic tremor. Okay, just a dystonic jaw tremor. It's really hard to check now point for jaw. But he has other dystonic features like he has very mild facial grimaces that look like blepharospasm spasm.
That's about it.
So after the movement started 2 years ago, were they getting worse?
Not at first, now it seems like the last 6 to 8 months it's gotten
So
worse.
once in a while, seeing the forehead contraction. Okay, there's some first, and there's some crackers. So he had no obvious problem swallowing. So now tell me what, do you have any problems drinking water?
No,
No problem.
but it just leaks a little bit. It does, I can't make it right,
So
hit
it's
the cup.
other than that,
Yeah.
let's try some crackers. So problem is chewing. So now you start to see sustained jaw opening and also tongue popping. So those are these dominant features. Okay. Yeah, so there's an example of this dominant jaw tremor, tongue tremor. Again, refractory to medications, did not improve this Botox injection. Eventually got DBS as Swedish, and really with some minor improvements.
Was there a known cause of that?
Idiopathic. Like a lot of things in neurology. Yeah. Okay, so for the remaining time we have, we'll talk quickly about myoclonic tremor or rhythmic myoclonus. So most of the time myoclonus happens pretty randomly, not rhythmically, but occasionally myoclonus happens rhythmically. So they can look tremor-like. We use the term myoclonic tremor. You can confirm the myoclonus nature with motor physiology. There are several types of myoclonic tremor and rhythmic myoclonus. Cortical tremor, mini-polymyoclonus, myarrhythmia, and finally palatal tremor / myoclonus. The important thing is that they don't respond to tremor medication. Usually they respond only to benzodiazepine. Okay, so what's cortical tremor? So it's first described in the 1990s, just kind of fast myoclonic movements. As cortical nature and the myoclonus nature were confirmed by tremor analysis of motor physiology study. It was first reported in epilepsy syndrome, but later people observed that it was kind of quiet conditions. I've been seeing a few patients, mostly after hypoxic brain injury or after a stroke. This patient had a lung transplant several years ago, and they had respiratory arrest after the transplant. And then he woke up and developed tremors, very fast tremors. Yeah. Like your nose. Touch my finger. Your nose.
my finger. It's good. Give your right hand. Now use your left index finger to do the same. Touch your nose. Slower. Okay, touch my finger. Okay, touch your nose.
So very fast.
Touch my finger.
Okay, so his brain MRI showed diffuse cortical injury, and more on the right side, as well as tremor is more pronounced, on the left side. So it was cortical damage. So I did a quick, motor physiology with a accelerometer and also surface EMG. We show that the surface EMG, the burst, is very short, less than 50 seconds, using myoclonus in nature. So it's a case example of myoclonic tremor, which is cortical tremor in this case. So another type of myoclonic tremor is called mini-poly myoclonus. Again, it was discovered way back, first reported in people with, I think, muscular dystrophy or spinal muscular dystrophy, spinal muscular atrophy, SMA, I think type 1. Later, was also observed in people with brain problems. So it's called mini because the amplitude is very, very small. It's called poly because it's very, very fast. So that's why mini-poly myoclonus look very similar to tremor. But again, you can confirm the myoclonus nature by doing back averaging. So there's an example of mini-poly. So again, look jerky, and they're not entirely rhythmic.
Turn your arms upside down. Okay, hold it there. Yeah, for a while. Use your right index finger, touch your nose. Touch my finger, touch your nose. Touch my fast. Faster.
Okay, so typically we see mini-poly in people with minor brain injury at birth, mild cerebral palsy. Also in dementia, you start to see occurrence of mini-poly. Neuroleptics like Seroquel can make polyemia worse. Okay. So next one is myarrhythmia, oculofacial mastectory myarrhythmia. So typically, describing Weber disease. So personally, I haven't seen a case of OFM myarrhythmia. Now people start to think that the involuntary movement in NMDA receptor is like it's maybe a form of myarrhythmia. So this video I found online.
This patient was under the care of John Selhorst with CNS Whipple's disease. The eyes are showing constant pendular vergence oscillations. These are synchronous with concurrent contractions of the masticatory muscles, which are moving his jaw. Hence the title, oculomasticatory myarrhythmia.
Okay, so hopefully next time when I give the talk, I will have a video of my own patient with the OFM myoclonus. So finally, let's talk about another myoclonic tremor, as palatal tremor myoclonus. It can be idiopathic, it just happens, like in this case. Okay, or it can be symptomatic, caused usually by a brainstem lesion. And for idiopathic palatal myoclonus, it stays in the palate. But for the secondary or symptomatic palatal myoclonus, it spreads out a little bit, to the mouth, to the tongue, or sometimes to the neck. It can also spread out to the eyes. So in her case, spread out to the tongue a little bit. Also to the lower face, the chin. So that's how you can tell is a primary or secondary. So the last video. So those are a case of secondary symptomatic palatal myoclonus. But in his case, the movement spread out to his eyes, causing a very unique eye movement called pendular vertical nystagmus. Okay, so his problem is caused by a giant cavernous malformation in the midbrain. So, okay, so that's the end. So again, the tremor disorder can be quite challenging, but usually we start with the circulars. You think the tremor, cerebellar tremor, mostly alpha tremor, and Parkinsonian the tremor. The key is often the activation pattern. The distribution also help you. When things get a little bit atypical, think about other possibilities, other tremor disorders, or tremor in the mimickers. Okay, any questions? Thanks. Good. Okay.